What's going on, everyone? So today we're going to be talking about push dose epi, and kind of what it is, how to mix it, and we'll touch on some other things. So push dose epi, it's a small IV bolus in diluted epinephrine. So we have our 1 to 10,000. We're going to make 1 to 100,000 concentration of our epinephrine. It acts on both alpha 1 and beta 1 receptors. Just as a reminder, our alpha 1 receptors, that's our vasoconstriction, so it increases our blood pressure. Our beta 1 receptors, it gives us our increased heart rate, and it also increases contractility inside of the heart. So that gives us improved cardiac output. So it really acts heavy on those. This is pretty much definitive hypotension treatment for us in shock. Because we have short transport times to the hospital. If we want some more definitive treatment, then we would look at some Levophed, and we can talk about that a little bit. So how to mix it? What are we going to need? Well, first we're going to need our cardiac epi. There's quite a few different ways to do this. I'll show you one of the preferred ways. It gives us a little less room for error, and then we can go over a different way. So I would like to keep my cardiac epi in the epi syringe. So if we're making epi 1 to 100,000, what we can do is we can squirt out 9 cc's of our cardiac epi. I know you can't see it, I'm squirting in a trash can. All right, so now we're down to 1 cc of our cardiac epi. We'll go ahead and add our 3-way stop clock. This is kind of the cleanest way to do this. Leaves us pretty little room for error. And then we're going to squirt 9 cc's into our epinephrine syringe. All right, so now we got 9 cc's. That'll give us 9 cc's of normal saline and 1 cc of epi 1 to 10,000, which will give us epi 1 to 100,000. What we can do with this now to ensure that we don't confuse this for our epi 1 to 10,000. This is epi 1 to 100,000. We put a little tape on there if you got a permanent marker, and then we can write 1 to 100. All right, so now we have our epi 1 to 100,000 push dose epi. We will give 1 to 2 mLs of this every 2 to 5 minutes. We need to reassess after every time we give this. This is a slow IV push. All right, so that's one way to mix it. Another way we can mix it, which is a little less clean, but it's kind of a quick and dirty, is we'll take a cardiac epi. So we'll take this one right here, pop off the syringe. We'll take a normal saline. We'll squirt out 1 cc of normal saline. So now we're down to 9 cc's of normal saline. We will take a needle. We'll thread the needle into the cardiac epi, and we'll draw up 1 cc of epi 1 to 10,000. And now this will also give us epi to 100,000. All right, it's super important that we mark this so that we don't confuse this epi 1 to 100,000 with normal saline now. So we'll put this around here. I'd write a little more than 1 to 100. I'd probably write 1 to 100 and then write epi on there. That way we don't confuse this with just normal saline. All right, so this is another way that we can make epi 1 to 100,000. You can switch that up using the stopcock or the needle. There's not really a set in stone way to do it. There's just preferences. As long as you don't mix them up, that's the most important thing. This dose and this dose are the same. It's 1 to 2 mLs every 2 to 5 minutes, which equates to 10 to 20 micrograms every 2 to 5 minutes for reassessing. You can also, if you absolutely had to, use an epi 1 to 100,000 to make epi 1 to 100,000. It is not recommended though. You have to draw up exactly 0.1 mLs of epi 1 to 1,000 and then put that into a normal saline syringe, and that'll give you epi 1 to 100,000. Once again, it's not recommended. If we for some reason run short on cardiac epi, then that's what you'll have to do. I'm not even going to show that in the video. If we somehow for some reason have a shortage, I'll make another video doing that. All right, so this is just a quick down and dirty how to make your Epi 1 to 100,000. You can use a needle, stick it in there, draw it up. You can use a 3-way stopcock. Stopcock, a lot cleaner, a lot safer in the back of a rescue or in the middle of the night. That way you don't stick yourself with a needle. But there are different ways to do this. There's nothing set in stone. Remember, what we're looking for is we're looking to get our systolic at 90 at least, or our MAP above 65 for our hypotensive and shock patients. Our pediatric dose, we're going to do 1 ml every 2 to 5 minutes. For our pediatrics, we're looking for a systolic blood pressure above 70 plus 2 times age in years. All right. If you got any questions, feel free to reach out. We need to just continually remember that we need to reassess vitals. We need to make sure we give fluids before we give any kind of pressors, because giving a pressor without any fluids, there's no squeeze to any juice. So we need to remember that. All right. Hopefully y'all enjoyed this. We'll talk to y'all soon.